Thank you, Jan. In absentia, lots and lots of food for thought. I'm going to invite Deb to come back up. We have a wireless mic, Deb, so you can roam, if you wish, on the stage. I just want to, while Deb's getting herself organised, I don't know about you, but as a health practitioner, when I first heard that it took on average 17 years for me and all my colleagues to change their practice, I didn't believe it. Now, probably like a lot of you in the room, I have been practicing for more than 17 years, and now I believe it. Because we're very stubborn. We stick with what we know, it feels safe, and we're a little bit mistrusting. Although we tout the new and we advocate best practice, it can be very difficult to actually find our way there. And I guess that leads me first question for you, Deb, in relation to this. Jan talked a lot about how we have been able to change practice, but perhaps not in the ways and to the extent that we need. I mean, from the example of being given a sweet by the dentist, the visit, to the Morris dancers who do the same thing. And I think there is a bit of Morris dancer in every health professional. Not a bad thing necessarily. But how could we, do you think, so your thoughts on how we can potentially start to shift more actively and in a more timely fashion from the evidence that we do actually gather, because we don't always have it, but when we do have it, how can we start to facilitate that shift? It's not quite so glacial into more evidence-based practice.
I think some of the things that she spoke about this time, about the behavioural changes and the process she goes through, I was quite blown away by that. I think that's a really good thing and something we probably haven't done enough of, even though we've been talking about how do we do that better. But one of the things, and I think as I said before with Martin talking about the Oral Health Martini Clinic, it's actually having, and Christabel was talking about this morning, clinicians are very competitive about their health outcomes and doing the right thing, but we don't actually provide data easily to people. And so I think one of the things will be in the co-design is helping to provide the evidence so people can look at it and go, are we making it better? I mean, I am also really horrified sometimes about how long it takes, and I think of particularly some of the prevention, early intervention, minimal intervention discussions that have been around. I mean, that was being published when I graduated. Now, that was a few years ago. I know I cover up the grey well, but it's paid for. But it's been a long time, and it's a lot more than 17 years we're talking about. And that evidence already exists, so we actually know the answers. And most of the things that we're talking about, both for value-based healthcare and also for the school dental van thing, there's a lot of evidence there. But what we need to do is to get clinicians to be looking at it and going, which bit are we going to aim for, which clinical guideline, and NEDs, I've seen so many times people not following clinical guidelines that cause people to live or die. I mean, we're not in that situation, but we have a huge effect on their health outcome. So I think it's going to be working together, establishing this is the guideline we want, and then using data to check and see how we're going. And it doesn't, and it's, as Christabel said, it's not about a witch hunt, it's about actually comparing, going, how can I do better? How can I get it better?
And I guess that's the interesting irony, isn't it? Because we focus so much on our patients' behaviour change, and that is a key, it's a cornerstone of contemporary practice, and yet practitioner behaviour change, we assume that practitioners are going to approach that cognitively, but of course it's highly emotive.
Yes.
And we forget sometimes that practitioners are occupying that emotive space and quite protective. So just to that point about you saying that we are competitive in terms of seeking to provide best practice care, and that I know that the ICHOM, I've been looking at what standard data sets are from the patient's point of view. Once again, your thoughts on how we can bring that sort of cognitive and emotive side of practitioner behaviour change into a safe space? Because I know we say we need to do it, but how do we make that process safe? Because I know whenever somebody says to me as a practitioner, oh, we're going to change your behaviour, or we're going to seek to actually monitor you in order to do that, I have to say, I don't know about you, but my back gets up just a little bit. I'm a little bit concerned about the motives. So how do we create safety in that process for practitioners?
Yeah, I think the example of the Martini Clinic, if any of you get an opportunity to look at it, you should read it up. the thing that blew me away from it is not so much the health outcomes, I mean, they're great, but what it was as peers, it didn't matter who you were in that organisation, whether you were the person that opened it, ran it, was in charge of it, they had this continual improvement attitude. They were always looking at trying to do things better. They had journal clubs where they were constantly looking, even in languages that they couldn't, all of them could read. If they found somebody that could and it was good, they'd have it translated and then look at how can we use that information to make our surgery better. There was this constant wanting to improve things. And I think that that's something that is not about being, that's actually about humility too, as a clinician, saying, I'm not always the best. And in fact, one of the great examples is the person that ran the Martini Clinic, started it, etc., is that he at one stage had, the cancer margins on, as he was taking, I'm probably getting a bit out of my depth here, anything below the clavicle, but he had a situation where he had cancer in the margins, much higher rate than he should have. And the deal was that whoever wasn't performing well went to the person who was performing the best and got retrained by them. And he went back and got retrained by one of quite younger colleagues, apparently. And his view was, that's the deal. That's what I'm meant to do. I've got to get better. And sometimes in health we're a bit hierarchical and we don't always accept that you can always learn. But we have to make that where that's the norm, I think.
It's an interesting challenge. I think I also liked what Jan was talking about as a segue to that, about her murder example, about the requirements of murder being motivation, capability and opportunity. And I guess beyond opportunities such as these, in terms of what do you see as some key capabilities to facilitate the move from, once again, this theory of we need to be doing this because we know it works, to actually supporting practitioners do it? How do you actually actively, is that implementable guidance that Jan referred to? That it's not just rules that are great in theory, motherhood statements potentially, but they're not implementable. So how do you do you think from your experience, look at that? How do you actually facilitate capability building in this context?
Look, I think it's firstly you've got to be willing to have the changes or participate in them. And I think that it is a capability building thing. We've been doing it this way for a long time. And sometimes that's what makes us very good, particularly if you're procedural, doing the same thing over and over again in a really measured, systematic way makes you very good at what you do. But what you also need to be prepared to do is to get feedback and think, well, actually, maybe it does need to tweak, or it needs to seriously tweak. And part of that is training ourselves how to do that. And I think particularly in the way we were trained, maybe less so nowadays, they're more likely, is we need to be trained to be open to new capability building. And certainly from a DHSV perspective, we're really aware of the fact that even going into our new school dental van scenario in the future, we are not reproducing the school dental service from when I started. I was a school dentist right at the beginning. We are not replicating that. It is a new world. It is many years on. The environment is different. We have learnt new things. We have new evidence. So we have to design a contemporary school dental van service. And we have to be open to that. We're not reproducing what we've always done. So I think if it's about being open to change, it's about accepting that we will help as much as we can from a school dental service point of view. And we will share with people like Jan, because they're already a long way on. We don't have to reinvent the wheel. And we keep doing that too often. If there are people out there in the world that are doing it well, that's, my favourite saying is plagiarise, plagiarise, never let anybody else's work evade your eyes. That is Tom Lehrer, not me.
And I guess this is this challenge for all of us with evidence. I mean, I'm secretly hoping that, as Zoe was referencing with the dental vans, is that we do actually get evidence to support a glow-in-the-dark flying dental van. I'm sort of secretly hoping that becomes evidence-based. But I guess this just last question before we conclude for a morning tea. a lot of what we do in healthcare, no matter what craft group we come from, doesn't have evidence at all. And money and ethics will potentially preclude us from ever obtaining evidence. So have you got any thoughts about how we occupy that evidence-free zone? That is, I would suggest, Jan said a third, I'd suggest in medicine it's probably 2/3 of what we do. Just wondering how you'd sort of occupy that space, given that's also the brave new frontier that we're seeking to bring practitioners into and through safely.
Look, it's a good point, and having worked in acute health like you, you're right, there's a lot of things that we do that actually affect people's lives, death, living or not, that there is no evidence base behind, but you'd need to think very carefully about a double-blind study that withdraws a treatment that you've traditionally done, particularly if somebody may die as a result of it. And I know that's a real ethical dilemma for lots of health organisations. A lot of the work that we've been looking at so far from a dental perspective, it has actually got a lot of evidence behind it, particularly the prevention side of it. We've got some really good evidence, although one of the things that I want to be sure that we talk about when we talk about the value equation doesn't just apply to clinical care, it applies to prevention as well. You don't want to be doing prevention that doesn't actually add value. It's there about improving health outcomes. So we've got to be careful about what we choose to do, and it's not that it was a good time, it seemed like a good idea at the time, which I certainly had experience of in the early 80s, so lots of prevention in that space. So I think that we're fortunate, we've got more evidence, and it's about how do we apply it, and I think then it's the capability building and making sure we provide all that information, and then the data going back to people saying, okay, are we on the right track? Are we following the guidelines and things like that? And if not, why not? Some of it will also be about creating the evidence. And we're a really large organisation. I don't mean just DHSV, all of us here in the public sector. We can do an awful lot about collecting data. We've got a fabulous database. It's all linked. So we can actually, and once we start getting this health outcome data from ICHOM, I think we'll be able to really clearly look at some things and go, is it actually making a difference? So it's going to be a combination of use what we already know about and also create some of our own evidence.
Okay. On that note, more food for thought. Thank you, Deb. What I'd like to do now, and of course, Professor Jane Clarkson in absentia,